This podcast is sponsored by PAX. Whether on the water, on land or in the air, PAX bags are both versatile and flexible backpacks that are perfectly suitable for your requirements in the most demanding of environments. PAX bags are highly regarded due to their exceptional performance in pre-hospital and in critical care environments. Their well-organised compartments and customisable configurations enhance efficiency in high-stress situations. They're designed with infection control in mind and are easy to clean and disinfect. So highly visible colours and reflective strips aid quick identification and adherence to quality standards, ensuring reliability. So the versatility of PAX bags caters to diverse EMS providers, and they deliver vital equipment, durability and ease of use for pre-hospital critical care services globally. I've used PAX bags in a number of critical care situations, and they're absolutely excellent, both in identification of kit, but also in identification of the reflective strips to ensure visibility. So please see the show notes for further details.
You're listening to the Pre-Hospital Care podcast on the Medics Academy Network.
Welcome back to the podcast. In this episode, we're going to look at common paediatric pathologies with Sarah Edwards. So in the episode, really want to focus on the subtle range of symptoms that can sometimes rapidly evolve into medical emergencies. Making it essential for us really to be well prepared to recognize these subtle signs and manage them effectively. So in the episode, we're going to explore some of the commonly and frequently encountered pediatric pathologies, including respiratory infections, gastroenteritis and dehydration, febrile illness, seizures, and asthma exacerbations. We're also going to discuss how to identify these conditions in the field and prioritize interventions and deliver high quality care. We're also going to delve into the nuances of paediatric assessment and management. And finally, we're going to look at the importance of communication with caregivers and how their insights can guide clinical decisions. So to do this, I'm joined by Sarah Edwards. Sarah, welcome to the podcast.
Thank you very much for having me.
It's great to have you with us, actually. Sarah, just before we start and I hit you with a barrage of questions, could I just get you to maybe unpack your background?
Yeah, so thank you for inviting me to the podcast. It was an absolute pleasure. So my name is Dr. Sarah Edwards. I'm an emergency medicine consultant, both in paediatric and adult emergency medicine. And I currently work in the East Midlands in the United Kingdom. I've got a range of hats that I wear, everything from for the Royal College of Emergency Medicine. I am their e-learning chair, so I look after all the e-learning stuff that the college offers. I do some lecturing in medical education, and I'm a senior editor and social media editor for the Emergency Medicine Journal. So sort of got a variety of skill sets, hopefully. But why I'm really here is because I do PEM and I do a lot of it. And that's one of my passions.
It kind of tees me up actually nicely for the first question, Sarah, which really is around the common pathologies. And if I could get you to speak really from your anecdotal practice, really, Sarah, around maybe the top 5 illnesses and or conditions that pediatric patients commonly present to you with from paramedics and or pre-hospital staff, and I guess in a way, and reaching back into your maybe last 6 months of practice, how do they stand out in terms of prevalence and severity?
Yeah, I think particularly with children versus adults that I see, I think there definitely feels most of the time there's a seasonal variation. So over your sort of winter months and into your spring sort of months, and this applies no matter whether you're north of the globe or south of the globe, you typically get your respiratory illnesses, bronchiolitis, viral induced wheeze, asthma. And then with all of that, your febrile illnesses, which of course can happen at any point of year, but all your respiratory type stuff, as I've said, happens, usually in that sort of winter period. And then we've got all the gastroenteritises, which often to me seem to peak around when kids go back to school, and then they're on holidays for a bit, and then they go back to school or nursery. So those sort of things. All times of year, really, trauma, whether that's a simple trip or fall or falling off monkey bars or the trampoline park, through to, the full spectrum of, seriously ill trauma. And then thinking about sort of, allergy always crops its rear ugly head up.
Yeah, indeed. Well, let's just start with, like you said, from a seasonal perspective, really some of these respiratory illnesses such as bronchiolitis and asthma. Could I get you to speak to maybe just some of the takeaways really in assessing and managing bronchiolitis and asthma in the field, or indeed in the emergency department. Some of the top of mind things that you're thinking about.
Yeah, so I think what I just wanted to speak to the listeners about is really I want to talk broadly about bronchiolitis, viral induced wheeze, and asthma and what they mean, because I think one of the challenges is with, lots of people is unless you work with children a lot of the time, people's confidence, can be mixed, and that can make people, understandably, even somebody who does this as a career, get a bit anxious about that poorly child that they see in front of them. So bronchiolitis typically is that sort of respiratory illness, snuffly, um, you know, noisy chest, breathing really fast, usually goes off feeding. And usually that typically is in the patient that is less than 1 year old. Can stretch up to 2 years old, but usually, the ones and unders. Next sort of comes the pathology of the viral induced wheeze, which sort of starts in that sort of 1 year all the way up to sort of 3, 4, 5 years. And this is much more predominantly wheezy in nature. So you see that child, they're breathing really fast. They've got that typical wheeziness that you would expect. And very much, that age range as they get a little bit older, sort of 3, 4, 5, sort of moving into that sort of asthma territory, which lots of your listeners will probably be familiar with. See it really commonly. And, very wheezy, breathing fast, all of those sort of typical sort of asthma symptoms that you're getting. And I think the one takeaway thing that I want to emphasize is for bronchiolitis, for those particularly under one, they can sound wheezy, they can sound crackly, they can sound all of that. They can have a low grade temperature, so 38, even 39 degrees centigrade. They can look really tired, they can be working hard, not feeding. But the key thing is with bronchiolitis, and that I always stress with all my juniors when I have the opportunity to just chat to the pre-hospital staff and the students, is please do not give them salbutamol, please do not give them nebulized saline, please do not give them anything like that. It is symptomatic relief. So oxygen, fantastic. If they're a bit warm and a bit grumpy, great, give an antipyretic such as paracetamol or acetaminophen. But nebulizers don't work. Lots of the other things that you might want to give to make you feel better, that you're giving something to hopefully try and make that child feel better, and the anxiety, please don't in bronchiolitis. When you're sort of moving into that 1 year plus and it's predominantly wheeze that you can use, by all means start thinking about trying a nebulizer, or if you've got them, or if they happen to have had viral induced wheeze or they have their own inhaler, use that blue inhaler, predominantly blue, so Ventolin or salbutamol inhaler, giving 10 puffs through a spacer, and that's really important. And I think for me, I think it's just really understanding, and it's hugely challenging, that bronchiolitis versus that viral induced wheeze asthma patient. And the asthmatics, I'm speaking to an experienced audience here, I'm sure, but asthma is hugely life-threatening, and we really need to get that treatment in as early as possible with those inhalers or nebulizers, whatever we've got access to.
Yeah, listen, fantastic, fantastic. And like you said, it's prudent to sometimes slow down in your decision making and understand, as you said, why the medication is being given in the first place. Let's just pivot slightly. This is going to be a broad ranging conversation, so we're going to go about 100 miles an hour. But I would like just to pivot slightly and look at dehydration and gastroenteritis. Actually, they are common and frequent in younger children, and indeed represent quite a substantial caseload, I'm sure, within emergency departments. Could I get you to speak to, in your mind, Sarah, some of the key signs of dehydration in children, and indeed how pre-hospital teams can best manage fluid loss in paediatric patients?
I think, firstly, recognizing that a vomiting child or one that's got vomiting and diarrhea is hugely stressful. And it's not to say none of what we're talking about today is hugely stressful, but I think there's something about food and not eating and not drinking that really stresses everyone out. And, I think recognizing that, and I'm sure everyone does. For me, really important things to think about are try and get a blood sugar. That's really, really important. No matter what age, that really can help you. I've been caught out so many times in my career thinking that it is, oh, it's just a bit of gastroenteritis, and it turns out to be a diabetic ketoacidosis, or turns out that they've got really low blood sugar. And thinking about, looking at that child, you know, observations, A to E assessment, those basic things. But, how are they? What are they behaving like? What is it the parents are worried about, or the caregivers? Have they weed? When was the last time they weed? And I think one of the things that's really important is that it's difficult when you've got diarrhea, because it's likely that children are weeing, but you just can't see it because it's all mixed up there. Truly dehydrated children, I think, are quite often easier to spot than those ones that you don't know where they're sitting. They're quite sunken eyes. They just look really withdrawn and really quiet. They've not really weed at all in the last 12, 24 hours. They might be very lethargic. They might have a low blood sugar. So those are some of the things that I'd be thinking about.
Yeah, indeed, absolutely, and like you said, that lethargy and lack of engagement is absolutely key, and in a way, resourcing the parents to kind of understand their normal baseline versus not normal baseline. But so pivoting slightly and looking at febrile illness, classic, lots of presentations of febrile illness, and really difficult in a way because it is so ambiguous, and there's so many pathologies which start with febrile illness. Could I get you to speak to how you differentiate between some of the more common conditions versus the serious conditions like meningitis or sepsis?
So I think I'm going to pivot it the other way, which is, so sepsis and meningitis, fortunately, in most of the world, is very rare in children. In places where vaccination perhaps isn't as robust as it could be, obviously you've got to be thinking about that more broadly. So, but generally, sepsis and meningitis, thankfully, in most children, is rare. So I think I'd start with that. It's the thing that lots of clinicians worry about. It's hospital or pre-hospital clinicians. They don't want to miss a meningitis. They don't want to miss a sepsis. And I think it's recognizing the other side of that is that febrile illness is hugely, a regular thing that we see with children. And I guess a bit like with the dehydration and gastroenteritis is really understanding what age is that child. So if this child is less than 3 months and they have felt warm or they've had a fever, that is sepsis until proven otherwise. So NICE guidelines, so the National Institute of Clinical Excellence in the United Kingdom, and lots of other national guidelines around the world, is, fever under 3 months old is an emergency until proven otherwise, is sepsis. So no ifs, ands, or buts, no getting the parents to drive them to the emergency department. They've just got to come. As they start to get over that 3-month age, the fever and that febrile illness just need to really, take that history, find out what's going on. And lots of the things that we've already talked about. How is the child? What are they like? How long is it going? The really septic children are, and the really meningitic children are hopefully obvious. And, they're lethargic. Their observations are all over the place. They're not weeing or haven't weed at all. They look grey. They look ill. And for all of the listeners out there, I'd highly recommend a free resource called Spotting the Sick Child, developed over 20 years ago using real life videos of sick children. It's a free online course. You can get a certificate for it and you can work your way through it. Highly recommend it. And I think the other thing that I worry about is how long have they had the fever? So kids can have fevers for a couple of days. Yeah, that's fine. And they'll be grumpy, they'll be fed up. But as long as they're sort of as long as they're drinking, as long as they're weeing, they're generally looking all right. You give them antipyretics, or you might give them something like ibuprofen, just to help with the symptomatic relief. And generally they're okay with it. If they're sort of getting to day 4 and 5 and they've still got their temperature and something's not quite right, I want to see those children in the emergency department. There's some really rare conditions called Kawasaki's, which is where you get persistent fever for over 5 days. It's a vasculitis, and that is an emergency. Meningitis, I'm sure our listeners are familiar with, with rashes, irritability, just not quite right, high fever and all of that. So I won't dwell on that too much, but those are some of the things that I'd be thinking about with, those febrile illnesses that we see.
Yeah, indeed. That's fantastic. So absolutely fantastic. And we'll put in the show notes a link to Spotting the Sick Child. I'll link that in the show notes for listeners. Moving on slightly and just looking at seizures. Seizures again is a broad church of symptoms, signs of symptoms, but well, signs really, and really, there's so much you can differentiate from seizures. But could I get you to speak to certainly febrile seizures are super common within pre-hospital care. Could I get you to speak to the best approach that you adopt for managing a child experiencing a seizure, and just how you maybe come to differentiate the organic nature of that seizure?
So I think you alluded it to into the introduction to this little bit about seizures. So for me, is it febrile or is it afebrile? Because those two pathologies are very different. And then the other thing with that is I always think about the age. So and whether they're febrile or afebrile. So typically, if we talk about febrile seizures, for me, along, so usually sort of 5, 6 year old children, sort of the maximum that I'd be expecting that they will get febrile seizures. It could be any age up until that point. And then, non-febrile seizures, so if they haven't got a fever, can be any age. So, and both essentially you manage the same way. You do an A to E assessment, you make sure the patient is safe. And if they are continually fitting, whether they're febrile or non-febrile, and they're getting to that 4 or 5 minutes, you need to start thinking about, well, what medication do I need to give? And usually it'll be a benzodiazepine, so that might be Bucolam, so midazolam. It might be rectal diazepam. In some services they can use intravenous diazepam. Whatever is on your prescribing, you need to give it. And ultimately, to me as a hospital provider, if they are still fitting at sort of 3, 4, 5 minutes and you're struggling, you start down that medication route to manage that. And again, while always managing that A to E, and thinking about those little things that again have caught me and every now and again still catch me out, and I should know better. Checking a glucose, don't ever forget your glucose. Checking that the story makes sense. So I've had, unfortunately, some really sad safeguarding cases where actually it's been trauma related, especially with little ones. And actually it's discovered that they've got, intracranial issues from trauma. And also thinking about, is what's is this a known child, and is this normal within their seizure patterns? And I think we'll come on to touch upon this when we talk about parents and caregivers. Actually, if this is a child that is known to fit and they've got whatever type of seizure history they may have, or they've got a complex background, really rely on the parents and what they would typically expect to see with that child, what their strategy or plan is from the hospital. And if it's not working, just believe them and, get them to help as soon as you can.
Yeah, I think that's fantastic advice, actually. No, fantastic. Something you said earlier, which is, like you said, I guess substitutes or indeed supplements caseloads throughout the year is trauma in pediatrics, and very tricky from a wide spectrum really of presentations. But could I get you to speak to sort of how common injuries differ between age groups and some of the priorities in managing pediatric trauma. I know anecdotally, falls were a classic case for me, falls off a bed in the very young, and or just dealing with anxious parents in that regard, but certainly not dismissing subtle signs and nuances within smaller pediatrics. But could I get you to speak to your experience really of managing pediatric trauma and some of the priorities in your mind, Sarah?
So for me, again, age is such an important thing, but I think it's about mobility of the child. So is this a child that is walking? Or is this a child that shouldn't be walking? And actually, what's the story that goes with it? And I hate to always, think about safeguarding, but it's hugely important. And sadly, safeguarding and non-accidental injury in children is prevalent. And actually, as pre-hospital providers, you are often the first people into that family's home, and that can really get an interesting insight that I will never get because I'm in a clean hospital building. So, what is common? So I see lots of little ones who were in their car seat or, been carried up and down stairs by parents, and they've fallen and they've dropped them. That is really, really common. And again, the most common injuries I often see with those, particularly with little ones, particularly with babies, because they've got soft, squidgy skulls, as I like to say, is that unfortunately they often either break their skull and they sometimes end up with a small bleed. So often they won't mark, and often they won't have much of a bruise on their head. And because their skull plates are open, they can get away with a bit of bleeding without them really not, without them you really noticing, because they've got the space, fortunately. So for those little ones that are non-mobile, really honing in the history, getting that sixth sense that you're at home going, nah, something doesn't feel right. Oh, yeah, no, absolutely. I can see what's happened. And most parents I meet who have done, dropped their car out the car seat, so easily done when you're tired, or you're walking up and down the stairs in a hurry and you slip and you fall. It's so common, and the story makes sense. And most parents I meet are absolutely mortified. And then talking about those sort of non-mobile children is thinking about, does the story make sense? So whatever the story is, that's important. And as you get older, the story is always important, no matter what age of child you're seeing, but particularly with trauma, is what the child's saying, is what the parent's saying, or whoever was with them, does it make sense? And fortunately, for lots of places in the world, big sick trauma in children is thankfully really, really rare, due to the advent of seatbelts and general safety features, but you do still see it. And whether they are, 6 weeks old, 6 months old, 6 years old, or 16 years old, the principles of trauma management apply. So it's A to E assessment, so airway, breathing, circulation, disability, and your environment. Don't forget your glucose. But also, particularly with the bigger kids, actually, even in big traumas, I would try and get the parents and the children to work together to keep them as safe and as wriggle free as possible. And even if it's the worst accident in the world, and you've got a screaming child and they want to be held by their parents, sometimes that is better than pinning them down to a scary bed in the back of an ambulance, trying to board them and put collars around them and all of that. So work with the parents. So my bottom line really is, with trauma in pediatrics, is what is the age? Are they mobile or non-mobile? Does the story make sense? And irrespective of whether they're 6 weeks, 6 months, 6 years, or 16, do your standard A to E assessment, trying to immobilize them where possible, but be a bit flexible in what you're trying to do so that you can give some comfort. And that might involve them being sat in the parent's lap.
So looking at asthma now, so as a wide-ranging conversation, we're shifting pace again, but just looking at asthma, which it really is a leading chronic condition within children, and There is this gradation and indeed, I guess, spectrum of asthma presentations and asthma exacerbation. Could I get you to speak to from your practice, Sarah? Because there is clear differentiation and like you said, clear guidelines around asthma. Could I get you to speak to some practical pointers around escalation of care and indeed, I guess, in your mind, some red flags that you really want to pay close attention to when looking at children?
So with asthma, again, really common. And I think I've reflected on, with the pandemic, particularly with lots of people being, shut up and us all in isolation and, banned from going out, for lots of years, actually, asthma we didn't see at all. And, actually now it's sort of come back. I'm not saying that the pandemic has caused the asthma or anything like that. What I'm suggesting is that it's just changed how the disease is presented. So the asthma, you know, is unpredictable and can be at any times of year. Thinking about asthma, the sick asthmas, they look tired, they're breathing really fast, you're giving them nebulizers and they look absolutely shattered, like they look as though they just want to fall asleep. And sometimes they look grey, they just look, as though they're going to fall off their perch. Conversely, sort of the other end, so those, viral induced wheezes, those asthmas, I think what we really underestimate is the utility of a good spacer and a good salbutamol inhaler at the end of the spacer. So nebulized salbutamol is brilliant, but it has its disadvantages. It's noisy. Kids often don't like it. Most of what you give goes out into the ether, and versus that with a spacer and an inhaler where you can give 10 puffs to somebody who is less sick, that can actually get you out of a lot of trouble quite quickly. It is a bit more challenging because, people do wriggle. But actually, the delivery of the medication that you're giving with that salbutamol is much more reliable. And particularly if they're breathing really fast, that can be really helpful. And in a lot of guidelines, particularly in the UK, actually for asthma exacerbations in children, provided they're not on the life-threatening end that I've briefly discussed about, using inhalers with spacers is a much preferred option due to the reliable nature of giving the medicine. So that could be easily done in the community, on the back of the ambulance, in participants' homes. And what that may enable you is that you give those 10 puffs. So one puff every 30 seconds to a minute, make sure that they're breathing it in over 10 minutes. It takes a while, but actually that might get you out of trouble. It also might allow you to go, well, actually, the child's not too bad. They might be able to make their own way to the hospital and then free up that resource. That's not to say, please, if you need to use nebulized salbutamol or ipratropium bromide, please use that. But sometimes that isn't better because of all the stuff you lose in the ether. So it's just thinking about it in a different way.
Looking at croup and upper airway obstruction, just as opposed to maybe asthma, could I get you to speak to just really how providers should assess and manage a child with a suspected upper airway obstruction and or croup? That classic seal bark cough. But should it really be more of a hands-off approach and really to expedite care to the hospital, or do you advocate intervention? What's your thoughts?
So I suppose there's croup, which we're very common, as you say, that sort of seal-like barking cough, that familiar tone that you sat in the waiting room or you're sat and you're walking into somebody's house and you can hear that noise. I won't try and do it for the listeners. That would be slightly embarrassing, but I think we can all imagine that seal-like cough. So typically with these patients, they get the seal-like bark cough. They've recently, not often, but sometimes they can have a preceding respiratory illness or viral illness or what have you. And particularly, it always seems to sound worse at night. Don't know why, but it does. And one of the useful tools that can help assess how severe it is something called the Wesley Croup score. So this may be something that our listeners are not familiar with. And essentially, it's a little chart that can help you quantify how severe the croup is. And it looks at things like chest wall retraction, stridor, whether they're blue or not, so cyanotic. Hopefully we can spot that, how conscious they are, and what their air entry sounds like. And we could probably pop it in the show notes and people can have a look at that. And that can be really helpful, because sometimes it's really difficult if you're in the pre-hospital setting to convey over how worried you are about a child. And actually, to someone, going, well, actually their Wesley Croup score is really high, it's 9 or 10, the child looks unwell, I'm bringing them in, or I might need some backup. That could be really helpful. And with all these sort of upper airway things, the other one that, fortunately I've only seen a handful of times in my career is epiglottitis. Less is more with all of these. So again, using those caregivers, using as much hands off as you can whilst trying to be safe and give treatment. So if they're not tolerating the oxygen mask right next to them, that's fine. They can have wafting oxygen. If, it's better sat on mum's lap, all the better, because if that airway gets compromised, and I've seen it in croup, unfortunately, and I've seen it in epiglottitis, you want to be somewhere with people that know how to get you out of trouble.
Yeah, listen, I couldn't agree more. Actually, absolutely, absolutely, and just trying to keep the child stable and calm is key. Just looking at allergic reactions and anaphylaxis, with most of these pathologies, Sarah, it is a spectrum, and it's a spectrum of presentation and of severity. But could I get you to speak to really how you, because there is lots of atypical presentations, and I think that's sometimes the problem. It's often not the classical signs which present. But could I get you to speak to maybe some of the identifiers of anaphylaxis, maybe albeit some atypical identifiers that you see in children, and indeed some of the key differences when managing children versus adults with anaphylaxis?
So I think for anaphylaxis, I think we really need to appreciate that symptom onset is usually very short. So it's within minutes of, be it ingestion, be it exposure to the skin, it'll be within minutes. If it's an hour or 2 hours down the line, it's less likely to be anaphylaxis. And, anaphylaxis, can present in a variety of different ways. So, rash, facial swelling, throat swelling, eye swelling, difficulty in breathing, hypotension are some of the symptoms. But true anaphylaxis is within minutes usually, as opposed to sort of the broader allergic reactions that sort of come up over hours or long minutes to hours. And those typically usually constitute as sort of itchy rash, a bit swollen. They might have a bit of diarrhea, a bit of GI upset. They might be vomiting a little bit, but true anaphylaxis, and that's why the guidelines have changed mostly worldwide, is usually within minutes. And the first treatment and the only treatment is adrenaline. No antihistamines, no steroids, just get that adrenaline in. At worst, and they didn't need it, they'll feel a bit tachycardic and a bit like, oh, I'm floating. At best, you've saved their life because you've got the adrenaline in. Adrenaline doesn't really have negative side effects apart from you feel a bit funny for a bit because your heart rate's bounding along. But that's better than, an airway that you can't manage and a dead person.
Oh, absolutely. I couldn't agree more. Absolutely couldn't agree more. I think it's absolutely key. Looking at sepsis now, we've mentioned sepsis slightly within the episode already, but and something you've mentioned actually, which I think is really key, is that fatigue and lethargy, where the child just isn't themselves, and like you said, the parents, mum and dad, is just saying he's just not himself. He's just not himself, and almost that as a nondescript, non specific piece of feedback is actually still super important to acknowledge that. But could I get you to speak to pediatric sepsis, and recognizing the signs? But like you said, I mean, there's the absolute signs of non-blanching rash, and starting to become
Mm.
prolific across the body. But again, there's maybe subtle signs before that. What's top of mind for you, Sarah, when managing sepsis?
I wish there was an easy answer to this. And I think it just goes to show how uncommon sepsis is in children. And I think it's just seeing enough children with febrile illnesses and just getting a sense of what they look like. For me, something just doesn't feel right. And it's really difficult for me to quantify. And I really appreciate in a podcast that's really not what you want to hear. But if they're really septic and really sick and, clapped out, as I like to say, and really lethargic and grey looking, that's really easy. If they're running around, eating a packet of crisps hot and then occasionally get miserable, that's, obviously not sepsis. The ones that you're asking me about are those ones that are in the middle and you don't know which way they're going to go. Time is really, really important, and don't underestimate time as an observation tool. If in doubt and you think the child is septic and you've got the ability to treat them in the pre-hospital setting, try and do that if you think that's the important thing. But for me, it's usually a balance of what are their observations like? What does that child look like? Are they what you expect them to look like for this febrile illness? What are the parents' concerns? And parental concern is really important, but it's got to be balanced against your clinical acumen and your clinical experience. And sometimes I don't know. I genuinely don't know. And sometimes I'm like, do you know what? I'm just going to put a cannula in. I'm going to get some bloods off them and I'm going to give them some treatment because I just don't know. And then I'll wait. And again, some of that is time. And I wish there was a really big answer, because you can go and, read all you want and you can go and do all the textbook answers. But sometimes you just need to look at the child and go, something's not right here. Let's treat them and we'll sort it out after.
Yeah, I think that's absolutely key. Absolutely, the adage of time and being able to, and unfortunately in the pre-hospital environment, that isn't something which clinicians have the luxury of. But to your point, Sarah, it's
Yeah.
actually move the child to a clinician that does have the adage of time. And
Yeah.
and like you said, it's something whereby if there is that niggle in the back of your mind, or there's the
Yeah.
atypical presentation and you can't pin it down, even if their observations are just slightly deviated, or there's just something,
Mm.
and it's like you said, it's then, I guess, in a way, sharing that burden with
Yeah.
receiving clinicians down the line,
Yeah.
who can just, like you said, sit on the patient, sit at adage of time, and start
Mm.
to work out a working diagnosis, and or see which way they go in the process
Mm.
of time.
The one thing that I think we're probably really bad at clinicians, confusion. So children do get confused. That isn't normal. And particularly in sepsis. So that is a real big red flag to me. And I was just thinking while we were just chatting and I was chatting out to you and listening, confusion. So particularly, it's difficult to tell when they're little, but as they're getting, 6, 7, 8, and they've got more personality and kids are talking or what have you, for them to start getting confused, or you're teenagers and they're doing daft things, or they're walking into things, or they're behaving oddly and they're febrile, that is really worrying. So I just want to, I appreciate that pre-hospital clinicians, like in-hospital clinicians, hear some bizarre stories, but confusion in febrile illness makes me really worried.
Yeah, indeed, indeed, indeed. So just as we come into land, a couple more questions, Sarah. One would be around, and it kind of tees me up nicely, really, around this non-specific illness, which again is a broad church, and can start with either lethargy or vomiting or irritability, or indeed pyrexia. Um, could I get to, so there is, in a way, um, like you said, red flags really. One in my mind historically really would be irritability, just if they're becoming, like say, confused, irrational, or extremely irritable. And lethargy as well was a red flag for me. The floppy child, that just extremely lethargic, skin, and it's something like you say you almost can't confer on a podcast, which is pallor, just this general paleness. And if they're
Mm.
doing their best efforts to look like Casper the Ghost, it's not generally doesn't bode well. And even if you can't pin down a specific diagnosis, that pallor and or diaphoresis absolutely is, for me, just it doesn't sit well with me to either A, refer into the community, or B, not provide continuity of care through to the emergency department. Could I get you to speak to the vague symptomatology? You've mentioned something already, just which is key, just the adage of time, and actually, I think that is just a key takeaway. You can afford the adage of time, but by taking them to hospital and giving them to a clinician base which do have time to look after them, and I think that's a huge learning point there. But just could I get you to speak to just vague symptomatology that you probably have to deal with every day, Sarah, to be honest? And is there any top of mind advice that you could give around vague symptomatology?
So for me, whether I see adults or children, um, the one thing is, what is that patient, or the parents in this case, concerned about, and really unpick that. We talk about um, ice is a small mnemonic, so having insight. So what is it you think that's going on? What are your concerns, and what are your expectations of what this interaction is? We talked about lots of signs, symptoms, time, but actually sometimes it's just bottoming out what is it people are actually worried about. And what they're worried about and what they're presenting with are sometimes worlds apart. And it just takes somebody to sit down for 5 or 10 minutes to bring them back down to planet Earth and out of the ether. Gotta love the internet, gotta love Dr. Google, but sometimes that doesn't help as well. And I've had many patients recently who thought they were dying of cancer, and they turned out to have something much more positive that was going on for them in their life. So I think it's, what is it they're worried about?
Yeah, absolutely, absolutely, and realigning expectations, and as you said, and I've seen this as well. Absolutely, is not negating the concerns of the parent, and actually, if there is no time critical things happening with a pediatric patient, it doesn't negate bringing the parent along on that journey, and
Mm.
actually making sure that you align and their expectations, and probably de-escalate their concerns in some which way. Absolutely. So just as we finish off, and let's go there, because the parental concerns and communication, I think, is fundamental in pediatric emergency medicine, and just how you navigate those conversations. I love that mnemonic ice, and I'll put that in the show notes as well, just so people can go back and reflect on that. But could I get you to speak to how you resource the parents, and indeed both their concerns, and how you translate clinical findings to parents in understandable language, really, and just, I guess, in a way, resource them for baseline, because they're abundantly and the most familiar with that patient.
So I think you hit the nail on the head with, bring the parents on the journey with you. They are your ally here. They are the person that will cuddle your child, calm them down, hopefully, uh, you know, provide that stability if you need to put a cannula in or something like that. And I think it's about bringing them on that journey. Again, as I said, really understanding what their expectations is, what their worries are, and what they're hoping for with this interaction. Often when I'm talking to parents, I often set what I'm seeing in front of me in the spectrum of what I see generally. I think it's really difficult when you've been up all night, you've had a kid that's been unwell, you're shattered, they're shattered, everyone's grumpy, nothing seems to be working. You're feeling like a failure as a parent. You're feeling like a failure in the world. And it feels as though you are the only person that this is happening to. So I bring it back to reality for them, which is like, you've done amazing. You're doing well. This is rubbish. I get that. However, what I'm seeing in front of you is your little Tommy or Charlie or whoever it is unwell. I absolutely recognize that. But for the children that I see, they are on the better end of being unwell than on the really bad end. So that is a good thing. So whatever you've been doing has been fantastic. What we're going to do is we're going to take them from home here or wherever they are. We're going to go to hospital and let's see what they say with a bit more time, and then we can come to the bottom of it. And I think that's what I do, all my patients. And I try and give, even though it's busy, those couple of minutes and about explaining what my expectations are, explaining what my pattern is, what I expect to happen. And also recognizing, and I'm really honest with my patients, going, sometimes we do get it wrong. But if we do get it wrong or things don't go the way we expect, if we've discharged you, always come back. I don't mind. If it's 3 o'clock in the morning and you're worried that something doesn't feel right, come back, because ultimately the parents are the child's advocate. They know them the best. They spend all the time with them best. I spend a fraction of their life or a fraction of my time in their life. Their parents are there all the time. So it's really being humble and honest, keeping language simple, but recognizing the challenges that the parents have faced, that they've done as well as they can to get them to where they are, and that hopefully we can make things better. And then if it doesn't get better, this is what we expect to happen, and have that honest and open dialogue.
Yeah, no, that's powerful and a fantastic place to finish. I think that even the narrative there is brilliant, Sarah, because like you said, it's affirming and it's acknowledging that they, like you say, might be at the end of themselves from a fatigue and just a patient's perspective. So yeah, it's that's fantastic. Listen, thank you for the last 45 minutes. It's brilliant just to resource your insights and understanding, Sarah, and indeed just get your perspective on your experience, because it's great just to be able to resource that. So thank you so much.
Thank you. No worries.
You're listening to the Pre-Hospital Care podcast on the Medics Academy Network.